Hi, my name is John Burroughs. I'm President and CEO of the Burroughs Healthcare Consulting Network, and I'd like to talk to you today about how to fix the U.S. healthcare system. You know, it's interesting with all the political noise around the Patient Protection Affordable Care Act, or Obamacare as it's more commonly referred to, it really didn't fix the healthcare system. Yes, we'll have another 32 million covered lives. Yes, the insurance companies won't be able to deny you based on a pre-existing medical condition. But the problem is, if we're really going to get serious about fixing healthcare, there's some things that we really have to do. So let's talk about the U.S. healthcare system. Why do we have to fix it in the first place? We spend more per capita than any other country in the world. In fact, almost double any other country in the world. And yet, what do we get for that, all that money we spend? We're ranked 39th for infant mortality, 43rd for adult female mortality, 42nd for adult male mortality, and 36 for life expectancy. So why do we spend so much and get so little? That's what we have to fix. So what do? First of all, we have to rationally and humanely ration healthcare. We'll talk more about these in a minute. Reform Medicare from a pay-for-volume to pay-for-value system. 3, create patient accountability and incentives. And 4, create a medical jurisprudence system. So let's go back and talk about each of these one at a time. First of all, we have to rationally and humanely ration healthcare. Interestingly, we already ration healthcare. How do we do it today? We do it economically. If somebody doesn't have insurance, they don't get healthcare. If someone can't afford insurance, they don't get healthcare. If someone's employer can't afford health insurance, they don't get healthcare. And if they can't get healthcare, yes, they can always go to an emergency department. But if they get cancer or heart disease or some complex medical condition, they really can't get the treatment they deserve or need. So what we should do, like other countries do, is rank order healthcare services by cost effectiveness. Governor Kitzhaber, governor of Oregon, did this in a very brave way. He secured a task force and asked them to rank order all the Medicaid, DRGs, or diagnosis-related groups, into rank order of cost effectiveness. And up near the top was childhood immunizations. Somewhere in the middle was coronary artery bypass graft surgeries, and somewhere near the bottom was liver transplants for people with chronic alcoholic liver disease. And then he went to the state legislature and said, how much do we have to spend on Medicaid patients this year? And they gave him a number, and he said, you've just purchased the first X number of Medicaid DRGs. That's what we have to do as a nation. And no one's ever had the political fortitude to want to do that. We have to enable access to everyone for medically necessary care based on federal and state budgets. We lose money every year because people wait until their medical condition becomes incredibly complex or difficult to manage or expensive before they see a doctor or go to an emergency room. We need to be able to provide preventative health care services to everybody, whether they can afford it or not. Why? Because that will lower the cost for all of us, not only purchasing health care, but buying health care when we need to buy it. Now, for people who can afford more health care, they can purchase it in the private market for supplemental coverage. There's no reason why anyone who has the money can't go to an insurance carrier and say, I'd like more insurance to cover my deductible or my copayment. There's no reason why you can't do that. But to have public sector coverage for everyone and private sector coverage for those who choose to purchase more, we have to get serious about rationing health care. Number 2, we have to reform Medicare from a pay-for-volume to pay-for-value system. Why is that important? Well, first of all, when we pay people fee-for-service, and when we pay more for certain services than others, we reward physicians and hospitals that provide certain high-cost, high-margin services. But we don't reward people who provide excellent quality, excellent service, or who lower the cost of care through more cost-effective health care. Interestingly, Medicare is eligible for people who are 65 years or older, and that figure came out of 19th century demographics when Otto von Bismarck created the first social security system for Western Europe. And we're still using that figure today. Many 65-year-olds are gainfully employed. They can afford health care coverage besides Medicare. Why do we keep it at a level that many people are still working? Reimbursement should encourage patients and physicians and hospitals to do the right thing. When you pay people to do more procedures or more tests, you don't reward them for providing better service, better care, at better quality and at lower cost. We need to start reimbursing around the things we care most about. And we need to start paying people based on what's medically necessary and not what has a higher margin. For instance, many cardiac catheterizations are not medically indicated. Many back surgeries are not medically indicated, and yet we continue to spend a large amount on procedures that have no proven medical effectiveness. Number 3, create patient accountability and incentives. Now, we talk a lot about the patient partnering with their physician and hospital, but we don't really mean it. Why do I say that? There's no patient accountability whether they smoke or not smoke, drink excessively or not drink excessively, wear a helmet when they drive a motorcycle or not. And yet, they're doing things and making decisions that has a profound impact on the cost of health care. So we should modulate premiums based upon good health care choices. If a person decides to diet and exercise, they should pay a lower premium. If they want to be in compliance with recommended preventative care, they should pay a lower premium. If they choose not to smoke, they should pay a lower premium. And you want to create empathetic and cost-effective options for end of life. For instance, people spend 30% of their total healthcare dollars taking care of themselves and being taken care of in their last 6 months of their life. Why do we put all this money and all these resources into people when we cannot meaningfully extend their life or their quality of life? We are the only nation in the world that allows third-party coverage for critical care services when someone has a proven terminal disease. Now, this has become a very polarized political question, and it's been called death panels, but every other nation has found a way to provide a humane end-of-life care. The United States still struggles with that, and we still want to provide critical care services when there's been no proven medical value to doing that. We should enable patients to be true partners with physicians and hospitals, not merely beneficiaries. And the only way they will become true partners is to have both a clinical and financial stake in their own outcomes. Finally, create a medical jurisprudence system. You know, the old tort system was based on 17th century English law, where someone was considered to be accountable for their individual actions. That's fine, except healthcare has become so complicated, and it's now provided by systems and complex processes that the old tort system of individual accountability may no longer be so relevant. What do I mean by that? Well, if doctors and nurses provide cost-effective care and they provide evidence-based medicine on proven clinical and functional pathways, and something bad happens to a patient, should they be held individually accountable for any actions which could be interpreted by a court to involve some form of negligence? Many thoughtful people realize that medical malpractice does not eliminate medical errors, it doesn't drive down the cost of care, and it doesn't protect patients. There should be a no-fault insurance type plan for patients who are unwittingly and inadvertently the victim of less than optimum health care. But if doctors and nurses in hospitals sincerely do the best thing by what they feel at the time is the best thing, should there be individual negligence? Also, doctors order a lot of unnecessary tests out of defensive medicine in order to try to prevent legal action. In fact, they spend over $300 billion in unnecessary tests every year. I worked in the emergency department for 30 years, and I can tell you, half of what I did was medically unnecessary for fear of a malpractice case. Also, many thoughtful people like David Marks have said there should be a balance between systems and individual accountability. This is called a just culture. And if people choose to follow an evidence-based pathway and something adverse happens, is it truly just to blame the individual for that? And finally, it really undermines the doctor-patient relationship when doctors and patients become adversaries and not partners. And that's something we need to change. As you probably know, Don Burroughs in the Institute for Healthcare Improvement said the triple aim for healthcare should be to improve the health of our population, improve the patient's experience of care, and reduce the per capita cost of care. Unless both Democrats and Republicans and the American public at large get serious about doing the things that we need to do, which involves the 4 issues of rationally and humanely rationing care, reforming Medicare from pay for volume to pay for value, creating patient accountability incentives, and creating a medical jurisprudence system, we will never truly have the healthcare system we deserve. So if you're interested in having this discussion further, please contact me at the email address on the screen, and I look forward to working with you on fixing the U.S. healthcare system and providing the kind of healthcare system that we know we all deserve.